Hello everyone, this is the time. My name is Sylvain Clousiez. I am the CEO of 3 hospitals in the Paris metropolitan area, and I am really honored to chair this session. This session, whose title is Digital Transformation, Artificial Intelligence, and Technical Innovations for Smarter Healthcare Delivery, will give us the opportunity to discuss some great experiences and to see how we can move together forward. Each of the speakers will be presenting, we'll have 10 minutes for this presentation, and we will all share a time for question and answers. For those joining us virtually, you are welcome to send us your questions by clicking the tab on the right side of your screen. For those who are here in person, you can also send your questions by first downloading the app, and once logged in, you can click from the home screen and select this session. To read more about the distinguished presenters, you can also view their profiles on the Congress app. So let's move to the paper presentations. And first of all, to our first speakers, Mr. Zane Ismail, who is the director of the Center of Healthcare Consumerism at Avia Health Innovation, Canada, and Kate Liebelt, who is the Director for Strategy, Operations, Pharmacovigilance, and Patient Safety at AbbVie, United States. They will tell us about how to address digital equity and global healthcare, people, process, and last but not least, technology. I'll give you the floor.
Thank you. Oh, Joyce. Perfect. Good afternoon. Thank you, Cedric, for the kind introduction. My name is Kate Liebelt. As mentioned, I work at AbbVie. I'm a pharmaceutical R&D leader. I am a former management consultant with Deloitte, and I am passionate about digital equity. It's an honor to be with you all today and to share the stage with my friend and collaborator from Canada,
Hey,
Mr.
Kate.
Zane Ismail.
How's it going? Hi, everyone. My name is Zane Ismail. I'm the director for the Center for Healthcare Consumerism at AbbVie Innovation, based out of Chicago. I'm actually a Canadian, though. Spent most of my career working in hospital systems in Canada, then jumped to the United States to working for Henry Ford. You saw Wright Lassiter's presentation, our CEO, yesterday, and then jumped into consulting on the digital side where I am today. And so super excited to share some insights with you all and case studies that we've learned over the years.
We'll do our best to keep it to 10 minutes. Next slide, please.
I think we change it.
Oh, do we change it?
Yes.
All right. Excellent. So very quickly, we know that there are many ideas being exchanged this week, and we want to empower each of you, no matter your role in the organization, to be champions for digital transformation, but most importantly, digital equity. So let's start with our beliefs, and we're talking a lot about beliefs and values, especially this day and age in healthcare. We do believe profusely that digital drives equity in healthcare. It means access, it means health literacy. COVID-19, as we've discussed now, certainly the last few days, has shown the cracks in the foundations of health systems around the world. And we know that access for vulnerable, low-income populations is key. Are you guys getting feedback in the back? I can try to
Just a little bit.
zoom back. Okay. Is it this? All right. We'll do our best not to break your eardrums. So when we think about digital access, we also have to think about things like the access itself, but broadband access. And something that is important to keep top of mind is that 50% of the world's population has low or no access to internet. Think about that. That's almost 3.5 billion. It's crazy. This is a key challenge that each of us is responsible for solving. Not to mention, what does life look like after COVID-19, if we can imagine that future? And the World Health Organization states, and we've had speakers from World Health Organization over the last few days share with us, we as a global society face increased cancer rates, heart disease, obesity-related complications, food insecurity, environmental challenges. The list goes on, and we're all familiar with it. But keeping folks connected in an equitable way is critical to confronting these challenges. Anything to add, Zane?
No, I think you covered it for the sake of time. So real quickly then, some of the objectives we want to talk about. First of all, just sort of gain a little bit of familiarity with some digital innovation frameworks, some that we're certainly using in the United States and Canada, that are a little bit more design focused than your traditional sort of legacy IT implementation. And then honestly understand the elements of successful digital equity strategies and where we might have used some digital care models to radically drop the cost of care and bring it into places where you may not even imagine. So when we think about digital transformation, just at least how we think about it, so to me, digital transformation really is incorporating sort of all the work and the ideas that go into sort of legacy traditional IT infrastructure and building that out with the complement of getting much more consumer focused. Certainly in the United States, unfortunately, healthcare is a business, and so we must think about it from the consumer and patient's perspective, but then also thinking about how that all links into actual new care models, new business models, so on and so forth. Equity is an interesting one. To me, the way I think about it, these are the innate differences that each and any of us have and the diversity that we can bring to the discussion. So as we're trying to come up with new ideas, we actually can. And then finally, digital equity for us is really making sure that everyone, no matter who you are, whether you're a taxpayer or not, can access medical services. And so those are just some definitions on how we think about this.
So just a word, we wanted to just call out people, process, and technology. You hear that a lot in consulting. It's a methodology that we really appreciate. But at the end of the day, it's really about looking at those different elements that can be brought together to move the needle from a healthcare operations perspective or from a business perspective, however you choose to address that in your organization. What we hope is that leaders understand at the end of the day what digital means for their organization, what cost-effective, patient-centered quality care means for their organization, but then they also develop an appreciation for change management, for communications, and for moving the needle on culture. A key thing too as we talk about people is that understanding, educating executive leaders and that understanding of the return on investment for digital. Now, I know some folks coil back at the notion of ROI in healthcare, right? It's a public service. But we're not just talking about financial ROI, we're talking about social ROI, social impact, which is a term I'm sure we're all very familiar with, as well as reputational ROI as well. And we'll talk a bit more about that throughout the duration of the presentation. But digital equity equals ROI, and helping your organization's leaders understand that is critical to transformation.
Thank you. I would add to that, I'd say I've had the privilege of being able to work with like very poor organizations, unheard of organizations, and very rich ones. And at the end of the day, it really just comes down to the people that ultimately makes the decision on whether or not that organization is able to be innovative. Really quickly, because I know we're getting close to time, process is one of my favorites to talk about. And one thing that we are certainly doing in the United States and in Canada and through some of the clients that I work with is teaching them new processes on how to innovate that you wouldn't ultimately or usually find within the context of traditional hospital systems. And really what I mean by that is starting to use more agile Scrum methods, things that are very common in true tech dev, starting to get them very focused around service design, which is something I bring from my hospitality background. I used to work for the Hilton, thought I'd go work for the Ritz-Carlton, but somehow ended up in healthcare. And so getting people really focused on the service of healthcare beyond just the clinical delivery, but how the health consumer experiences the whole thing, from the point of parking to leaving to additional communication that comes down. Getting them also really focused on strategic foresight, which would have been great through this pandemic, to start thinking 5 and 10 years ahead and using backcasting as a method to place ourselves in the future and start building today what we ultimately think we will need tomorrow. And then finally, I hate it, the waterfall project management method. That's why I crossed it out. We definitely need to stop doing that. and essentially building products and services that ultimately the health consumer or the patient doesn't exactly want. So those are some of the ways that we think about this. What you see here is a journey map that we like to use and work a lot of our members through to really help them map what are all the touch points and moments that matter in not only a care journey, but a consumer health journey that we can influence as the hospital institution. Technology specifically, this one is very important to really think through, and I'll just hammer the user experience, making sure that the tools that we launch are easy to navigate, that the languages are approachable, but most importantly that the design is palatable and approachable. And this is especially important as we think about more and more individuals with disabilities who are trying to access technology, not just those who are completely barred from it, making sure that those things are approachable, and then obviously managing the cost.
I want to just put in a plug for Rock Health, which is an organization based in San Francisco, but has really done quite a bit of research and published a number of white papers on health equity and digital. They offer 4 key elements of the equity-centered digital mindset. Work within the community that you're designing for, shoulder to shoulder. Have a diverse team, that's your internal team, and perhaps that vendor or service provider that you're working with as well, but make sure that there's diversity on that team as you're solutioning. Make the solution accessible, as Zane pointed out, many examples of that accessibility piece, and make sure that when you're building, you're not building in bias. And we talked a bit about that, I think, on day 1 of the session, actually, in this room in terms of bias in AI. So really think about not building in bias and then preventing bias from seeping into the solution that you've developed.
Okay,
so should we talk about our case studies?
We have 60 seconds.
Okay, so very quickly, I do encourage folks to look into the Priscilla Chan and Mark Zuckerberg San Francisco Gen white paper and data published on their expansion of telemedicine services during the time of the pandemic. And I'll cut to the chase. The idea is that broadband access is going to be critical to reach low-income and vulnerable populations. Very exciting to note, U.S. Congress passed a historic broadband funding and infrastructure bill, $1.2 trillion. So by 2023, we hope to see that infrastructure expanding to the most vulnerable communities. The New York City mayor just announced he's going to be providing, again, broadband access. So findings from the Zuckerberg General Hospital, key and I think totally translatable to other markets as well when we think about telemedicine strategy. Zane, did you want to talk a bit about Henry Ford in our remaining time?
Sure, really quick, because I know we're over time now, but this was a project I worked on. We were able to actually create ultra low cost, call it digitally enabled, exam-enabled video visit clinics within employers. So in the US system, health employers pay dearly for the claims that go out on their employees. So we basically would go in and do for General Motors, for others, we're in discussions with Ford, go into their corporate headquarters, go into their factories, and actually just find an office and convert it into a telemedicine studio that's run by a medical assistant, which is a very lower wage employee, and so we can run it at a very cheap cost. And the way that we've been able to do this is by utilizing TytoCare, which many of you might know. It's ultimately a Bluetooth-enabled device that allows us to start to actually conduct an exam. So it widens the aperture of what is possible to be done through telemedicine. It's not just audio now, it's not just video. We can listen to the heart, we can look in the eyes, we can look down the ear, we can listen to the abdomen, so on and so forth. So basically what we've created is a virtual urgent care model, very cheap. Employers usually pay cash for it, and so all their employees, some of which, especially in Detroit, are underprivileged, can access that service for free. And then it also helps the employer at the end of the year when they're renegotiating their claims with the payer. So just really cool model. You can Google it, it hit the news. So if you want to read more about it, or by all means reach out. Thank you all so much for your time.
Thank you all so much.
Zane and Kate, thank you for respecting your time and giving us an inspiring vision. We all remind this digital equity mindset that you have introduced, and I know that there will be some questions later to give you more time to express your ideas. But let's move to the second presentation. It will move us to Paraguay, and the title is to adapt teleconsultation to the public health system during the COVID-19 pandemic. Thanks to the support of the Republic of Taiwan, the first speaker is Dr. Hector Dami, who is the head of the IT department at the Medical School of the National University of Asunción, Paraguay. And the second speaker is Yuanan Wu, who is the project manager for Health Information Management Efficiency Enhancement Project in Paraguay at the Taiwanese International Cooperation and Development Fund. So, floor is yours.
Be close to the mic.
Okay.
Use first.
Yeah, I'm Tony. I'm from Taiwan, as the speaker introduced. And Dr. Dami is the head of the IT department in the National University of Asunción. We work together very closely during the pandemic, especially. So allow me to do a bit of introduction about our project first. In Paraguay, according to its national health policy, develop an efficient health information system is one of the most important components because the majority of the system were really not functioning well. So our project was initiated in 2016 through the cooperation with Taiwan ICDF, Ministry of Health and Social Welfare from Paraguay, and Cathay General Hospital, a very experienced hospital from Taiwan, with the target of developing a standardized health information system for enhancing the information management at the hospital operation level. We developed the system from scratch. We didn't translate the system we have in Taiwan and put it in Paraguay. And then we want to implement the system to all the regions in Paraguay. And our key performance indicator is the number of patients' health record collected will be increased by 50% on annual basis. At least 1.2 million of health records will be collected by the end of the project, which is in 2023. Our outcome, first of all, let's look at this photo. It was before the system was implemented. It's always usually very crowded. And after we implement the system, it's quite chilled down. And the patients can be admitted quickly, less queue at the admission office, and the managers can get real-time reports and with science evidence, right, for supporting their decision-making and allocation of resources. So our current status is we have implemented the system to 63 health facilities in 14 regions with over 4.4 thousand of end users, and there were over 3.8 million times of consultation made through the system, and we have collected over 800,000 patient records. Let's look at this interesting figure. This is the number of monthly patients treated or record collected. Starting from March last year, the number of patients dropped down dramatically. That's when the pandemic hits Paraguay. And because of government's strict lockdown policy, there were a lot less accidents for the emergency section. Also, patients were afraid of going to the hospital for receiving their treatment. Even doctors are also worried of working in the hospital. So, during this difficult time, we sensed the opportunity for positive changes during the pandemic. First, we believe there will be more usage of appointment because in the public health sector in Paraguay, no one were doing appointment. They all do drop-in service. And then we could also take this opportunity to adapt teleconsultation. So I want to show another figure of our outpatient appointment and teleconsultation ratio. As we can see, at the beginning of, April 2020, the percentage of using the appointment was relatively low. And in fact, we actually rolled out the appointment function since 2019 March. and no one were using it. But then with the, I shouldn't say thanks to the pandemic, but it actually brought some positive changes. Yeah, so the average now is about 16% for the appointment, and then the teleconsultation in the selected services is about 7-8%. So now I would like Dr. Dami to further explain about how their hospital works with teleconsultation. Dr. Dami.
Thanks, Tony. Well, a brief introduction to my hospital. Hospital de Clínicas from the University of Asunción, the second largest hospital, third level, and operating since 1894, and using the HIS from 2020. Closer to the mic. Okay. 2020. Well, we initiated teleconsultation with the high support of Tony and his crew members of the ICDF for the health project, his project. For telemedicine, teleconsultation, besides having the HIS system, it's mandatory for us to restructure our workflow. First of all, we need to create and develop a call center to receive calls from patients and confirm the appointment for the teleconsultation. Here you can see the whole flow chart. And finally, the patient family member can go to the hospital to receive their prescription. In the case that the medication isn't in the hospital, they can use the digital receipt. But at the same time, we have to do many other things in the structural preparation to the teleconsultation office for the doctors. This is an example of what happened in our hospital. This was the library of the hospital, and we use and deploy it in the service of teleconsultation inside the library during the hard days of the pandemics. And these are our numbers of the teleconsultations. You can see here the services that are using teleconsultation and the most important in number of patients. We did a little survey with the doctors inside these services about the potential advantage of using teleconsultation. And for example, in the Department of Endocrinology, they treat diabetes, and the prevalence of diabetes in Paraguay is 10% of the population. And they found that providing diabetes care effectively, they can reduce the number of hospital admissions. The other big service in number of patients is the psychiatric. Hospital de Clínicas is one of the two only hospitals that treat mental disorders in Paraguay. And doctors from this department use the teleconsultation to avoid face-to-face contact with the patient, most of them complicated. The other advantage that they have seen was easily treated and was too easy to stay engagement in the treatment of this patient in a close follow-up by teleconsultation. The other service, very important, was neurology. Neurology used teleconsultation mostly for those patients under chronic neurological conditions, and it fits well for teleconsultation. Now I will request Tony to come again for the conclusions.
Thank you, my friend. So now I would like to conclude my presentation about the key successful factors for our kind of project. First of all, the support of change management from policymakers is very crucial. And also the consensus building with the central level, the hospital managers and health workers. So it's like both top-down and bottom-up approach is required. And we have to listen to the end users, analyze their input, continue to improve the functionality of the system. That's one of our advantage. We develop the system ourselves, and most of the time, those brilliant ideas comes from the end users, really, not from the computer engineers. Yeah. And lastly, government will need to allocate operational budget to ensure the sustainability of the project. Thank you very much. That's our presentation for today.
Moltes gràcies a tots.
Gracias for your presentation and these impressive results in 18 months. Let's move to the third presentation, which is about an emerging e-health model and its generalizability in the healthcare system. I call Dr. Javier Borras, who is the medical director at the Hospital de la Santa Cruz y Santa Pol in the wonderful and amazing city of Barcelona, Catalonia in Spain.
Thank you very much for your presentation. Santa Cruz, São Paulo. Okay. I'm sorry, I'm alone. I have not a partner. Yes. And I would like to show you our experience with an e-health system. But first, I would like to show was not our system. The digital health is absolutely wide in there. And the word of digital health, we include robotics, enhanced vision, interfaces, but especially we use the term e-health or m-health, mobility health, to support the telemedicine, the approach of the patient, and the approach to support the needs from the patients. The accessibility is our goal. Sorry. Technology is always evolutive, always is innovating, but in several situations, several occasions, we have the tools, but we have no question for the tool. And at the end, as users, our medical people, our question is, what's the point? Why we need all this big data, robotics, Internet of Things? I'm sorry for the technical entrepreneurs, but sometimes this question could be, many times the question is capital. In this framework of the digital health, I'd like to show you our near 8 years experience with an e-health tool and the process of its evolution, at first very slowly, and at the end it was very, very fast. Well, I start. Once upon a time, we start with the m-health study. The m-health study was designed to assist patients with heart transplant. After the heart transplant, these populations has a very complex polymedication, not only because there are a lot of drugs, but also because the drugs have a specific, it's not the same to take in the morning, in the afternoon, or the interactions between the different drugs. Moreover, in these patients, the lack of adherence or to make mistakes can conduce to rejection and to the death of the patient. Then for the heart team, it was very important to introduce someone to help these patients. The focus was to have a strategy holistic with all the elements, multidisciplinary, pharmaceutical, doctors, nurses, rehabilitation, etc. And with the patient at the app designed for him. And the strategy was to induce behavioral changes, not only to say something, but to change the conduct of the patient, making consultation, the questions. The second phase of this study, the study that started in 2013, was to demonstrate that the improvements work really. And we make clinical trials, published these trials designs are published, but this one is it's a preliminary results, and we show the improvement of adherence from pharmacologic, and we show also improvement the patient experience, also the professional experience, and the last we are demonstrating that decrease of infections, number of hospital admissions for resection of the patients, and a decrease of cardiovascular risk markers, for instance, glycemic control. We have better hemoglobin, glycate hemoglobin. And, sorry, that's a quoted slide. It's during the COVID. It was not a serendipity, but it was not founded. It was additional found. 75% of patients use the mHeart every day. It was very useful. 63% of the patients consult the healthcare team. And for patients, they have a very, very good consideration about the ideas. It was a useful way. Then I take the parentheses, the quoted slide. For COVID, it was an easy way to sustain the use of the app. I will show you some differences slides only to show the screens, the time curve. That's the mHeart at the first. It's easy to use. We include here that date from adherence, vital signs, symptoms, schedule, drugs, task. Also, this mHeart is a platform that becomes a good line for the control for the status of the patient and also for the follow-up of vital signs. This other one is not mHeart, it's the evolution. Now the mHeart has evolved in the other, because I explained you that it starts very slow, but now it's going fast. That's changes of the platform for oncologic and hematologic patients. And we have different apps based in the same organization system and based on the same technology. And this last one is an application, a platform that we developed with the same technology to fed a follow-up of the hip fracture patients in a fracture liaison service. The fracture liaison service is the best system to control the patients with hip fracture and to avoid future fractures. All the tools are dotted with, have a app surface, an app presentation, and also web-based platform for individual or group control or to collect that. How to arrive to this development in apps? Well, as that we denominate as the motive of this presentation is the ecosystem. The ecosystem to obtain these results, it's a slow evolution system. We start in 2013. We continue with our pilot was the mHeart, and we validated first in 31 patients. During 2 years, we make the clinical trials to demonstrate evidence. And in the last 2 years, and in the middle of pandemic, a very needs from clinicians arise as a demand of the new apps to support the patient. the ecosystem is so complicated as that. There are a lot of departments, a lot of areas, and a lot of stakeholders to take in consideration. I would like to point online first the different services. The different services, gynecology, orthogeriatry, oncology, migraine, heart transplant team, the different clinical services are absolutely necessary, but they cannot be the coordinator of the app. Because if not, if we make cardiology, for instance, as the coordinator, as the leader, all the apps will be for patients with heart problems. But it's necessary to take out this coordination. And the direction is also very worried. It's difficult to engage direction, the managers. Then in our hospital, this role of leadership, the coordination, takes by pharmacy. Pharmacy, with the problem of polypharmacy and the adherence, was the first line to take this app and the developments, and absolutely leaders of the problem. And there are a lot of collateral areas, as ethics, the research, communication department, legal department, juridics, that are absolutely necessary to a good result. And of course, there are technology. Technology is the basis, and the technology is it's an evolving area, and it's not technology directly from the hospital. The hospital is here. We have our integration with our systems, but the platform and the apps are in a cloud system, absolutely differentiated. That make the guarantees for the security and for the availability for the patient. Finally, I will show you in our hospital different development projects. So one's in the first phase, functional status. Here we are patients with myeloma or patients with heart hematologic transplant, situations, treatment of the thrombosis in oncologic patients, or the other very important area with complexities, patients with frailty, with any one of these pathologies. And the in-health, the technology system is not from the hospital, it's an external technology. We make all the functional support, but this technology has evolved in other areas as the ECO in Catalonia or Hospital Gregorio Marañón, and in different hospitals has been evolving usually with a big success. What are the take-home messages? First, conditions to invest in mHealth system. It's very important that our patients has an app that makes a support that connects with the hospital. Not always. The conditions is, we think that it's very important for high complexity patients. It's not for very prevalent diseases, but very complex, where the high comorbidity, polymedication, when is more useful, because the number of patients that the resources that need from the hospital, from nurses, from the different departments to attend these patients is not lower. The second one, we like to say that we need apps with in situations that could be situations where are susceptible to behavioral changes, especially for pharmacy adherence, of course, no, but also when habit modifications can change the intercourse of the patient. And finally, it's this line is very useful when you have the multidisciplinary approach, because the holistic treatment, the app permits the patient not to interact with with different visits, but to interact in a holistic manner. And the requirements from the ecosystem are, of course, an involvement of entire organization is very, very difficult. It's easy not to be a success if there are only one department or a clinical department involved. Second one, it's an evolutionary process, and the first is slow, and the idea is not necessary to have a leadership imposed by the direction or by the system information, but that need to take out from the need from the patient. Usually the problem is how to improve the care of the patients, and that we have the response through the health technology. And I thanks with your presentation, my presentation, sorry. I will play it. Well, I finished the time. In the last slide, you can find not my email, but the email of Dr. Gomes, Mark Gomes. That's as the aim of this tool. Thank you very much for your attention.
Thank you very much for your presentation and for the take-home messages. In the next presentation, we will change the scale because we were on the basis of complex patients, and we will move to a more strategic vision of what we can do with all these digital innovations. For a general hospital, Fundació Sanitària Mollet, Mr. Serrano, who is the CIO, will introduce us about the key success factors of its technological evolution to artificial intelligence, how it moves on a general basis, and how we can change a network of institutions.
Thank you for this opportunity to explain our experience. Hi, I'm Alberto Serrano, CIO at Fundació Sanitària Mollet. I will try to explain in these 10 minutes how we have been incorporating technology until today and what are the key aspects to consider now in our way to be a smart hospital. First of all, I would like to present a few numbers about our institution. We are a non-profit organization that provides public social and health services in the Valles area. The Valles area is about 30 kilometers from here in the province of Barcelona. We offer health services to 11 municipalities and 165,000 inhabitants. And we are 1,400 employees. And we have these centers: an acute care hospital that was inaugurated in 2010, which is certified as a green hospital, a palliative and rehabilitation hospital, 3 residents, and our Obra Social Aurora that is doing community projects. Here you can see more numbers to get an idea of the size of our institution, the activity of our acute care hospital with a number of outpatient visits, emergency visits and surgeries, the activity of our palliative and rehabilitation hospital, the number of day hospital sessions, inpatient sessions, our area of mental health, and our 3 residents providing social care services. Okay, this is important. We are a growing institution. As you can see, if we compare the situation between 2010 and 2020, we can realize that we are today a very different institution. We have duplicated our activity, our staff, and the number of people we serve. And what was the turning point that caused this growth? Without a doubt, we believe that it was the new hospital built in 2010 and which we are very proud of. Well, let's talk about technology. This is our systems plan evolution. As you can see, SAP is our main information system, which began with a scope of billing and logistic processes, and currently includes all hospital care processes. But I would like to highlight 3 stages in this slide. First, in 2015, we incorporated, with the help of common management solutions, the SAP HANA technology, which allowed us to improve our processing capacity. This was a very important milestone for us because with this infrastructure, we began to be able to process a huge amount of data with high performance. In 2017, with Common Management Solutions, we implemented the new electronic medical record, our health information system. It was a very complex project where many people in our hospital worked in, and it was implemented successfully, and we are very happy with this project. And finally, the current moment, the present, in which we are implementing different projects with another partner, Palex. One of the projects is SteamTrack. SteamTrack has 2 different areas. On the one hand, it offers real-time information on the patient situation throughout the surgical process. In this way, you can reduce the anxiety of patient relatives and the stress of patient relatives. And this part is already finished, and we are very happy. It's working successfully. And on the other hand, SteamTrack is a machine learning tool. It's our first experience with a tool of machine learning. And this tool makes the operating room more efficient, using historical data to estimate the duration of the operation. It's our first experience, and we are currently implementing this tool, so I still can say if we are more efficient, I hope so, but we are implementing this now. Another project is the Omnicell automated dispensing cabinets of medication in inpatient units. With this project, we have eliminated the pharmacy diary process of filling unit dose cards to transport these cards to the nurse units for the drug administration, because this process was totally inefficient. Okay, and what's next? We have a lot of technologies, and well, we are open to any innovation that can add value to us. But we want to focus in the surgical process and in the medication process. Okay, so far, what have been the most important factors to achieve success? We believe that there are 7 factors. 1, the most important, financial sustainability. We want to be able to decide which projects we do. It's essential. We have to be an efficient hospital. If we want to make IT projects, this is a sacred rule, is our mantra. Strategic plans, of course, agreed with professionals, realistic but ambitious at the same time. Professionals, obviously, with their involvement in the projects. The use of interoperability through standard basics, especially since 2017, when we increased the exchange of data with devices and with another centers. The culture of excellence through continuous improvement and accreditations, such as the EFQM model or the Joint Commission accreditation that we achieved last year, with benchmarking, seeing other experiences and learning from the best, and with strategic agreements with the suppliers, with the IT industry. Okay, but now the question is, today, seeing what is happening with the IT sector, with the proliferation of new technologies and innovations, is this enough? We believe not. We believe that we have to add things in these 7 factors. In financial sustainability, I think that we have to try to agree on outcome-based or value-based healthcare financing models. We know that this is not easy, but we have to try. We don't want to pay for a tool. We want to pay for the benefits of the tool, and this is not easy. In culture of excellence, we must insist on continuous improvement, renewal accreditations, but I would like to highlight the term operative improvement more than clinical improvement. I think that there are many things to do in the processes of the hospitals. We have to get doctors and nurses spending less time on administrative tasks and focus on patient care. Maybe they are not very disruptive improvements like an algorithm that can diagnose a cancer. We know, but they are very important. Strategic plans, of course, we must open our organization to new models of care. We have seen this with telemedicine. The use of standards, we have to insist, but we have to insist in data quality. Predictive data models are useless if the source of the information is not of quality, and professionals must be aware of this. We have to expand benchmarking internationally, and leadership and professionals. At this point, I think that we have to change in many organizations. Look, I have an excellent team. It's a small team, but it's excellent. They have technical skills, of course, but what gives them the most value is not the technical aspect. The best value is the knowledge of the processes, the ability to understand the business, and what the professional needs and how the new technologies can help to them. We are a hospital, we are not a technology company, so what we have to achieve is to manage the projects properly and not to develop it. To develop it, the industry is already there. And finally, suppliers, or partners, from suppliers to partners. It is necessary to reach agreements with the industry, looking for win-win agreements, and create different partnerships. But what is a partner? A partner does not have to be a simply logo, a stamp in a document. A partnership must be written in a specific contract which involves both organizations to sit down once a year at least to monitor the partnership and think about how they can collaborate. If a partner wants to understand what we need, he has to know our culture organization. The partner has to breathe the soul of our institution. In conclusion, I will say that we are on the right way to be a smart hospital, but partnerships with the IT industry are the key to achieve it. I think that our institution can offer interesting things to the IT industry to reach this agreement. So if there is a supplier in this room or watching this streaming that has something interesting to show us, it will be a pleasure to sit down and talk each other to do something. Thank you.
Thank you, Alberto, for your striking intervention, which help us to understand how change management can be driven in an hospital with, of course, as you say, a long-term vision for 10 years, as you have told us, and key objectives with the clinicians. So it's really impressive. I would like every speaker to join us at the table and move to the questions time. I will just give me the privilege of asking the first question. by drawing a link between what we just have chaired in this Congress since day one, which is the importance of the human resources after this post-pandemic era, and we are all facing a lot of issues with the workforce, a shortage of workforce, and technology in 2021 can be also used to address all these questions. For instance, I am the CEO of hospitals in the metropolitan area in Paris, and due to increasing housing prices, it's very difficult to hire some nurses in the center of Paris, and it's very difficult to hire physicians in the remote suburbs of Paris. So we are, I would say, physicians in the middle of the territory, and patients and nurses in the outskirts of the whole thing. So if we think about telemedicine, it of course can be a very efficient tool to address all this question of inequality. And so, for the speakers, please could you react on the human resources challenge and how you did address these things when you were thinking about your different fields of interest?
Yeah, okay. Okay, I absolutely agree with you. Yeah, I think that in Spain is very similar. The number of physicians and nurses are scarce. It's difficult to find it. And I think that in Catalonia we have a situation where there are a good integration between primary care and the hospitals, and that's the system, the connection for interrelationship is not difficult. One other thing is the role of telemedicine to non-presential consultation or visit or follow up the patients. That was but I think there are two different things. One is the integration. The integration is, I think, is guaranteed because public health care is absolutely connected with hospital reference. I know that it's different than the French situation, for instance, Paris on the banlieue. Yeah. But for the telemedicine, of course, is a very useful tool, but is not considered by our the Department of Human Resources. It's not by the moment the skills that the requisites that our nurses or our physicians is not contemplated to have the skills in technology or abilities in telemedicine. That's your question is that, but probably telemedicine will enter because for many things. For instance, we have neurology departments or radiology departments. Many of the duties, the on-call, are done at home with the system of telemedicine to cover better the maximum specialist or diagnosis. That's the problem of in the hospital, the hyper specialization. Sometimes you do not need an expert. You need the best of them, and then the telemedicine is possible to help us, for the manager, to make the process to have the best diagnosis for emergency area, for previous to a thromboembolization, for something. I don't know if I ask you your question, but probably I tell my head of human resources to include skills in the next convocatory. Yes.
Thank you, but maybe a further comment?
Want to talk?
Sure, no, I'm happy to. You know, I think we talk a lot about patient engagement when we talk about digital strategies, but engagement more broadly does include the workforce, right? And I think that what we're finding now in the pharmaceutical industry, but I think this is true in hospitals, payer organizations, is that our workforce wants to be heard. They want to be understood no matter where they're located. And I think that what is incentivizing employees to stay, and what's a big part of retention strategies, is creating learning opportunities, creating a sense that when folks are close to that point of burnout, that they're being heard, that they're being cared for, and that despite virtual boundaries, well, there are no boundaries with virtual, creating that sense of community and support, and that's what is helping retain employees beyond pay.
You know, one other thing I'll share, so this is with my Henry Ford Health System hat on, and this isn't related to COVID, but it's always been very difficult for us to recruit clinical staff in the city of Detroit. It's a very depressed city. There's some nice spots now, but some of you might know the history. And so what we've been doing is we've been working closely with the city of Detroit and the state of Michigan and economic development to become a place-making organization. And so what that means is we invest in local housing, local investing in local supply chain. And part of that actually bleeds out onto our workforce, where at one point we were actually subsidizing rent and mortgages for people to come and work for Henry Ford Health System and live in the city of Detroit. And so that also might be an opportunity to work with your local governments in economic and community development and see how you both have an interest in keeping the hospital staffed, but also the community alive and vibrant.
Well, we have another profile as a low-income countries. For us, teleconsultation is an excellent tool to diminish the barrier to access to hospital. We have a terrible problem with access to hospitals, public hospitals. And with the teleconsultation, we make as a virtual triage. Only we choose only the patient needed to come to the hospital, and the others can be attended by teleconsultation. Most of them chronic disease.
Is there a question in the audience?
Somebody ask a question.
Well, I'll give you more time.
Can I ask can you have a question? Yes? Okay, for you.
Yes, of course.
Yes, of course. I absolutely agree with your idea that teleconsultation is a help. But I was shocked by the specialties of your slide of teleconsultation, and dermatology was the third. Then, dermatology, if you have not images, teledermatology or something that is not a good specialty in our experience. You have teledermatology implemented?
Not yet, but it's planning to have the pack and the server to install the image.
Yeah.
They are doing by WhatsApp right now, but they use dermatology as I said, as a virtual triage.
Yeah.
Those patients who really need attention, they select and do the presential. But at first, they do teleconsultation.
But
and for the follow-up of, for example, leprosy.
Okay. Yes, for the follow-up.
Yes, for the follow-up of leprosy.
Yes.
Or other chronic condition of skin.
Yeah, I very agree with you. But I think that is not it's not a type of specialty for the teleconsultation. That's the process.
No.
It's not the same. First visit, successive results of labs, and to classify for a specialist is more important it's the patient that needs the teleconsultation, not the doctor. Then to start, for instance, to avoid absolutely to make a visit of the patient to give results. That's forbidden. Then it's necessary to make that the physicians and the nurses believe that all the things that is possible to do without the patient need to be done without the patient. It's a bit mandatory, no? Yeah.
Yes,
I don't know if I explain, no?
maybe the bias be that we are one of the services that have dermatology.
Yeah.
Maybe two. There are two. There are two dermatology services, there are two neurology services, and two mental disorder services.
Yeah,
and
no,
the
I understand.
quantity of patient is very, very
Absolutely, yes.
high.
I think that the change of paradigm with the pandemic was that we were able to ask our physicians and nurses to consider that the reflex should be try teleconsultation, and whenever when it's not possible, then keep on physical.
Yes.
But the other paradigm that is to change is, I think, much challenging. Is to move to the hospital-centered and hospital-driven vision to a patient-centered vision. And usually when I'm discussing with staff, everyone says, well, I'm okay for digitalization, but I don't want to have a different vision, different systems. And for instance, in some specialties, people would be very keen to use your philosophy about complex patients, about follow-up patients, because they may think that it's something familiar to their vision, not the technology, but the vision.
Yes.
And what we have to address also as professionals is many people out of the scope, and where there could be more cost-effective and most efficient ways of putting them on board. And this is why I was pretty impressed by what you, I was ashamed because you only have 10 minutes, but when we were discussing the Ford initiative to have this low-cost, very effective way of putting people in the health system, and then to find the good pathway to how we, generally speaking, are taking it. Maybe this is a way of connecting all these presentations, not only on a question of scale, but a question of what's going at the philosophy of our system, which is think about how the real patients are, and not how we are used to treat them.
Absolutely.
So I would just add to that. There was a quote several days ago here at the conference about scaling versus replicating. And to those points, it really gave me pause. The goal may not be necessarily to scale a model that's worked in one scenario, one specialty, one geography, but to replicate those elements of the model to create something unique and specific to a population. And I think that mentality, replicability over scale, is going to be key in solving some of these challenges.
Absolutely.
Well, I don't have many questions coming from outside the rooms, so I'll be very pleased to welcome questions from the room.
It's clear.
Maybe a question. Is there anyone in the audience working currently on designing a digital health solution? And is there a challenge you'd like to share with us, or a question that's coming up in that work? Nobody.
Good question, though.
They're all-
Money and people.
All right.
Yeah. Other than that, all's good.
Yes. Okay. That's the hardest part.
I think we may consider that money is not as challenging as people.
Agree. Agree.
Though
That's a
it
good
might
point.
be challenging a lot of time. Okay, if we do not have any questions, is there a question from one to another that you want to address at this table? Well, otherwise, otherwise,
There's one back there.
One
Oh, yes,
question at
please.
the end of the.
Also, I had a simple question of just what was the tele-platform that you guys were using at Abbott that you mentioned had the ability to do, you know, more diagnosis?
Sure. So it's a company called Outpatient, and I think they're pretty popular in Europe too. It's a startup. I don't know if they're a startup anymore, but they're ultimately based out of Tel Aviv. So Tytocare, Tyto, awesome little tool. Our patients love it. We've deployed them in people's homes. We have them in employers. We use them with paramedics to go and do chronic disease consults. They're awesome. So check it out. Check it out.
Great, thank you.
No problem.
Thank you very much. It's about artificial intelligence. It's about bottom-up. It's about how we all have visions to connect together. So I really want to thank every speaker for this great presentation. We had an opportunity to discuss things today, but we surely will follow up because I don't think that this digital transformation will be ended before a lot of IHF Congress.
Yes.
So thank you, everyone. All of this will be available, of course, on the website, and please, we'll be pleased to see you physically in the next events. Bye-bye.
Thank you so
Thank you.
much.